Welcome to This Explainer. Today, we're unpacking a massive, almost invisible wave of global finance that is fundamentally changing the hospitals you and I rely on. It's a fascinating dynamic playing out right now, private equity versus local independent doctors. And we're using the state of Kerala as our blueprint because what's happening there today, well, it's highly likely to shape the cost of your cure tomorrow. So let's get right into it.
Section 1. A Doctor's Dilemma.
Let's dive into this with a deeply personal story to really ground the numbers we're about to see. This starts in a small town in Kerala's Pathanamthitta district with Dr. Charlie Cherian. He has spent literally decades of his life building St. Thomas Hospital from the ground up. It's an independent, doctor-owned hospital designed to be affordable for his local community. But right now, he's facing a terrifying, well-funded existential threat. He's actually worried that marquee investors are going to push independent doctors completely out. And why? Because keeping up with medical technology is astonishingly expensive. In just 4 years, a single advanced ultrasound machine is projected to cost nearly 50 lakh rupees. For an independent doctor, keeping pace with those soaring costs is incredibly hard. But for this new breed of investors, 50 lakh? That's just pocket change.
So, the crucial point here really comes down to one staggering number, $1 billion. That is the exact amount that massive global private equity funds have pumped into buying hospitals across Kerala in just the last 3 years alone. Think about that. We're talking about global financial titans coming into regional healthcare with an appetite that has left smaller, independent operators like Dr. Cherian scrambling just to survive.
Which brings us to Section 2. Why target Kerala?
Now, you might be wondering, why are trillion-dollar global asset managers targeting this specific state? Well, the morbidity data reveals what is essentially a captive market. A massive 94% of medically certified deaths in Kerala are caused by non-communicable diseases. We're talking things like cancer, diabetes, and heart conditions. Plus, over 41% of deaths happen in individuals aged 70 and older. When private equity fund managers look at this data, they don't just see a public health challenge, they see a highly lucrative market. It's an aging population dealing with chronic illnesses that require long-term specialized care. And crucially, it's a market largely funded by non-resident Indian, or NRI, wealth that's continuously being wired back home to pay for all this care.
Another huge factor is where patients are actually choosing to go. Kerala has a very robust government healthcare network, yet despite that, 63% of all hospitalizations are handled by private hospitals. Nearly 3/4 of outpatient care is in private hands too. So the vast majority of patient demand is already securely flowing right into the private sector. People have the disposable income, and they're more than willing to pay for quality care. And because of this intense, locked-in demand, the cost of care is uniquely high. The per-household hospitalization cost here sits between 9,000 to 10,000 rupees. To put that into perspective, that is double the national average in India. For global investment firms, this combo, high demand, chronic illness, and a willingness to pay double the national average signals absolutely massive revenue potential.
Let's move on to Section 3, the private equity playbook.
Private equity doesn't just buy hospitals randomly, right? They operate on a very predictable machine-like corporate strategy. It's a 3-step playbook. Step 1, buy. They look for a demand-supply mismatch and acquire stakes in hospitals that already have strong regional brands. Step 2, expand. They aggressively add beds and pump money into high-margin specialties, think oncology and cardiac care, while driving operational efficiency. And then Step 3, which is arguably the most important for these funds, exit. They aren't in this to run a community hospital for 50 years. They want to generate cash, consolidate, and ultimately cash out through an IPO or a sale to an even bigger player.
And we're seeing this play out in real time, right now. Blackstone, a firm that manages over $1 trillion globally, teamed up with TPG to drop roughly $400 million to acquire Kim's Health. Meanwhile, KKR acquired a 70% stake in Baby Memorial Hospital, and earlier this year pumped in another $210 million. Since that takeover, Baby Memorial has been on a hyper-aggressive expansion spree. They're taking over other multi-specialty hospitals, buying stakes in facilities in Kozhikode and Vellore, and even breaking ground on a 300-bed facility in Chennai. It creates this crazy self-reinforcing pressure. Once one hospital gets private equity funding and buys, say, robotic surgical arms, everyone else feels compelled to do the exact same thing just to compete. This shift creates a stark contrast in healthcare models. On one side, you have your promoter-led hospitals. These are your traditional doctors who build hospitals for their communities slowly, over a lifetime, focusing heavily on legacy and affordable care. On the flip side, you have PE-backed hospitals.
These are corporate-owned, fiercely focused on rapid scale, and completely driven by a fast exit strategy. Essentially, what a traditional doctor wants to do over decades, private equity demands to see done in just a few short years.
Section 4. The cost of cure.
So, what actually happens to the patients when speed, scale, and high-margin exits take over the operating room? Well, while we wait for long-term data in India, we can look at a massive 2023 study published in the prestigious Journal of the American Medical Association. They analyzed insurance claims from millions of hospitalizations in the U.S. between 2009 and 2019. The findings? Deeply concerning. They found a shocking 25.4% spike in hospital-acquired conditions at facilities after private equity took over, compared to those that remained independent. This included a sharp rise in patient falls and an increase in bloodstream infections. And keep in mind, this happened even though the patient population trended younger after the takeovers.
How does something like that happen? Well, local health experts in Kerala warn that to generate the massive cash returns investors demand, corporate managers apply immense internal pressure. It often starts with cutting manpower. Nurses with 10 to 20 years of experience cost more, so they're usually the first to go. Experts also point out that doctors are suddenly handed surgical quotas. A surgeon might be told they have 50 cases to complete, creating this pressure cooker environment where a patient who is only suspected of needing surgery might be pushed onto the operating table. And perhaps most quietly devastating for the wider community, many of these bigger corporate chains simply ignore low-margin government health schemes, leaving those without deep pockets or NRI funding completely out in the cold.
Section 5. Fighting for the future.
This brings us right back to the human element, the very real struggle on the ground for local doctors trying to survive this financial onslaught. Let's return to Dr. Cherian. His entire life has been subsumed by his practice. He notes he has literally never taken a foreign holiday. The farthest he's ever traveled is to Bangalore, and that was strictly for work. It's a grueling lifestyle, one that actually deterred his own children from going into medicine after watching him work day and night for decades. Yet despite the immense personal toll and the fact that corporate chains are getting bigger while tech gets more expensive, Dr. Cherian refuses to back down. He's determined to protect his passion-built hospital against the billion-dollar tide. As he says, we just have to figure out how to survive it.
As this Kerala gold rush continues, it's serving as a very real-time blueprint for the rest of India's healthcare system. It shows us exactly what happens when immense capital meets medical need. And it leaves us with this final, provocative question to think about. Should healthcare be treated as a lucrative asset class to generate outsized returns for global investors, or must it remain a fundamental public service? Ultimately, as the landscape shifts from community doctors to corporate boards, who do we really want controlling the cost of our cure? Thank you for joining me on this explainer, and I encourage you to keep questioning the structures behind the services we all depend on.